Welcome to Good Medicine, a podcast about the ideas, people, and conversations shaping the future of healthcare. I'm your host, Dr. Rohan Ramakrishna, neurosurgeon and co-founder of Roon. Each episode, we explore how medicine is evolving through honest conversations with leaders and changemakers. Good Medicine is brought to you by Roon, the digital home for doctors. We're a free, physicians-only community to connect, share knowledge, and shape the future of medicine. We often think of medicine as the interaction between one doctor and one patient. But what happens when the patient is an entire city, a country, or even the world? Today's guest, Dr. Tom Frieden, operates at that massive scale. As a former director of the CDC and NYC Health Commissioner, he has faced down some of the most terrifying threats of the modern era, such as leading the U.S. response to the spread of Ebola, battling tuberculosis in India, and transforming New York City's approach to smoking and trans fats. On the heels of his newly published book, The Formula for Better Health, we explore the high-stakes decisions made inside the cramped quarters of the White House Situation Room and the critical, often invisible work required to build trust in a skeptical world. We also dive into his framework of see, believe, and create, a method for making invisible threats actionable and breaking down the surprising big six behaviors that actually determine how long and how healthy you'll live. But as you'll hear, his approach isn't just clinical. It is rooted in his background as a philosophy major grappling with logic and his early days as a disease detective. Whether you're a physician, a policy worker, or just someone trying to live a healthier life, my conversation with Tom Frieden offers a masterclass in how organized action can change the world. Welcome to Good Medicine. It's great to have you.
I'm looking forward to the conversation. Thank you for what you do.
So I want to start with your pre-medical career a little bit. If I read correctly, you were a philosophy major at Oberlin. Is that correct?
Yes. Actually, my father said, look, you're going to be doing science and medicine the rest of your career. Do something else in college. And so I studied philosophy.
It's funny you said that. I had an English teacher in high school who told me the exact same thing. She's like, you must promise me that in addition to something in science, you do some hard humanities. And so I picked philosophy. But, I bring that up because, there's a utility to potential utilitarianism to public health and sort of your guidance there. So I'm curious, did that influence you in ways both conscious and unconscious?
I'm not sure. I do think that the very simple, clarifying question of how can we save the most lives is a great way of thinking about how to build an organization or a career. And obviously, there are lots of different ways to approach it that are all valid and important. The specific area of philosophy I worked on was Wittgenstein and philosophy of conception. And trying to apply that to ethical issues, recognizing that you can have philosophically inconsistent perceptions of a problem, which are both valid. And I think that's been something that has helped me to understand the world a little better.
Yeah, that's awesome. And so I'm curious, did you always know you wanted to go into medicine, or was that something that evolved over time?
I remember that my application for college said, I want to go to medical school. And my application for medical school said, I want to go into public health. So I guess I was a little bit ahead. I knew what I wanted to do. But my career, I've been really fortunate to have great mentors and great opportunities. And with that, I've learned, and I've tried in this book to convey what I've learned, and I learned a lot more actually in the process of writing this book.
Yeah, that's great. Now, public health is not, I would say, the usual path for someone who goes into medical school. So I'm curious, what started that fascination with public health? Because so many people go into medicine with this idea, I'm going to take care of the patient in front of me, but public health is all about taking care of millions, potentially, right? And so I'm curious, where did that frame shift, if you can call it that, kind of occur for you?
Well, one thing is I actually love taking care of patients. There are some people who go into public health because they'd rather not do clinical
Mm,
medicine. I love clinical medicine, but
mm,
um, I had done some policy-oriented stuff in high school and in college, and I was hiking with my father in the Blue
mm,
Ridge Mountains of Virginia, and he said, you seem to like policy stuff and you like science, and if you put those two things together, you get public health.
mm,
So that was the first time I'd ever heard of the term public
mm,
health. And then I'd done a residency in internal medicine after medical school. I'd done my MD and MPH, and I was working in tuberculosis control, which has such relevance both in the US and globally. And it was really through tuberculosis control that I came to understand some of the real details of what works in public health.
yeah. I think related to that, you tell a story in the book about how you're talking with your father, and he asks you, how would you know whether you're going to become the best health commissioner, right? And that idea of impact, right, is seems to be very profound throughout in your life.
Yeah, it was a very emotional moment. He had Parkinson's disease and he
Mm,
was fading. He was in a
mm,
nursing home and he was saying less and less. And I had just come back from India where I had been on assignment for 5 years working on tuberculosis. I was going to be the health commissioner for New York City. I told him, not that I'm competitive or anything, I told him that I wanted to be the best health commissioner. And he said,
mm.
"How would you know?"
Yeah.
And they were actually the last words he ever spoke to me.
Wow.
Because his health was going downhill. And it's a great question. He was a cardiologist. He was very rigorous in his thinking. He practiced evidence-based medicine before that term was invented.
Mm-hmm.
And it raised the question of, all right, what's killing the most people? And what are the things that we can do to address it? And that's really something that led to the formula for better health, this approach: see, believe, create. See things that may not be readily apparent, believe and strengthen the belief that you can make change, and then create a healthier future with organized, simple, well communicated programs that overcome barriers.
I love that, and we're gonna definitely get into the formula, which I think is hopefully for the rest of the conversation we can talk about how those different aspects of that formula relate to these different inflection points in your career. Where you start in the book, which is I think a fascinating one, is as a epidemiology intelligence officer in New York back in the early 90s. So first, can you tell me what goes into the training of some of our young officers that get deployed, and then also, paint the picture of New York at that time?
Sure. Wow. So the Epidemic Intelligence Service is the disease detective service of CDC.
Right.
And there were a series of magazine articles, mostly in the New Yorker, by a man named Bertrand Ruchet, who described these mysteries that disease detectives would solve, many of them at the New York City Health Department or elsewhere. It was a program that started in the Cold War, actually. Um, a physician named Alexander Langmuir began this at the CDC, and he got funding for it by saying, "Hey, we may have biological war, and we need some disease detectives." So
Hmm.
he was kind of clever in getting the funding for it, and the program has existed now for many decades, more than a half a century, and has a great reputation. They take somewhere around 60 or 70 in most years, doctors, veterinarians, dentists, PhDs, and put them through a 2-year service learning program. When I went through it, the initial course was about 3 weeks, if I remember correctly, where you are taken through a series of trainings in surveillance, how to evaluate a surveillance system. It sounds obvious. It's actually one of the most important skills in public health, to
Hmm.
see whether a system to track a disease is accurate, timely, practical, useful, and a series of rigorous assessments. And then you do an investigation. And I still remember our investigation. It had something to do with car seats and
Hmm.
what was the likelihood that people were using car seats if they had a kid in the car. This was 1990. And we did an observational study outside of a shopping center. And,
Hmm.
within a week, we had an interesting finding. So it's this idea of practical epidemiology or interventional epidemiology, where you're getting data to actually change something. I was born in New York City. I also went to medical school there, public health school there. I did my internal medicine residency there at the height of the AIDS epidemic between 1986 and 1989. And what that meant was that I spent an enormous amount of time taking care of people for whom I could do very, very little other than try to help them die comfortably. It was a terrible, terrible experience. I had volunteered to work in a men's shelter. They had 800 men sleeping on a drill floor. 200 of them had serious mental illness. And by state law, they needed a once-a-year physical examination and primary care visit. So I was doing once-a-year visits for these 200 homeless, mentally ill men. It was a time of a lot of homelessness, a lot of drug use. Treatment of HIV was still ineffectual. And so I had friends and colleagues who were dying from the disease. It was a rough time, a really rough time. And as I started, I got a call from a doctor I had known from some other work I had done saying she thought that multi-drug resistant tuberculosis was on the rise in New York City. And this was a hot tip about something that, as a police detective looks for a hot tip, a disease detective does also. And that led to a big study that documented that she was absolutely right. There was a massive outbreak, the biggest the U.S. has ever had. And that led to my being appointed director of tuberculosis control and assistant commissioner of health to help stop this terrible outbreak.
So, thinking about your framework of see, believe, and create, can you talk me through, how that applied towards the tuberculosis epidemic in New York City?
Sure. So it's, I'm going to give a little bit of the short version because the long version takes the whole book. But
right.
So it's 3 phases: see, believe, create. For each of those phases, there are multiple aspects. For the see, it's see the trends, see why we don't take action, and see whether programs are succeeding, and see the rigorous path to progress. So it's a series of things that have to be seen. The first thing that we had to see was this doctor, whose name is Karen Brundy, was she right that multi-drug resistant tuberculosis was increasing? That wasn't easy to figure out. I had to travel by subway around to many of the 72 labs that grew cultures to get them to ship it to CDC. CDC had to reculture them and do it. And in fact, there had been a big increase in multi-drug resistant tuberculosis. Nearly 1 out of every 5 patients in the city was spreading multi-drug resistant tuberculosis. The next question, the next mystery to solve, to see the invisible, was where was it spreading? And we did actually the first community-wide genomic epidemiologic study. And what that showed was that it was spreading in hospitals primarily, that hospitals were the epidemiologic pump sending out these patients with terrible infection control and resulting in a lot of spread and death. Once we could see that,
the pus buckets, right? Isn't that what they're?
Yeah, my supervisor, I was so wide-eyed and, wet behind the ears. I came back from these places collecting the samples, and I said, these places are totally disorganized. And she said, yeah. We call those places pus buckets. And she was right. Many of them closed since, and the rest of them, I hope, have cleaned up. I know they've cleaned up at least some. But so we were able to see that where it was spreading, and then we were able to see the pathway to stopping it with good infection control, good treatment, good follow-up. That was the see part of see, believe, create. The believe part, we began doing something to show that it could work. Because part of strengthening belief is you don't try to get from, A to Z on day 1. You go A to B to C, and then you say, oh, yes, we really can make progress. So we systematically tracked the outcome of each patient. We stopped each outbreak. And with each step, we built confidence of the program that we could make progress. I remember I was put in charge of the tuberculosis control program. There were 148 staff of the program. it was bombarded with patients. They were running 10 clinics. The clinics were falling apart. They couldn't get enough doctors. Some of the outreach workers were not doing, they were shopping instead of working. It was a mess. And I called the whole staff together and I said that I was proud to be part of the organization that would control tuberculosis in New York City. And people were shocked because they didn't think they could control it. But having that optimism is really important. And in fact, it became possible. So the belief is partly about optimism, but it's not blind faith. It's rigorously proven optimism. And then the create part is the hardest part. And that means organizing. So we had to organize well and simplifying. And here I was taught a huge lesson that has changed the way I think about everything since. There's a remarkable scientist named Carol Stieblo. He had created the global strategy for tuberculosis control. He came to New York City. I had been in charge of the program for about 7 months. I'd been working around the clock. And he looked at our data and he said, Dr. Frieden, this data shows me lots of things, but it doesn't tell me the most important thing. How many of the 3,811 patients that you diagnosed last year did your program cure? And I didn't know. And I was terribly ashamed. And at that moment, I began this simple approach of tracking the outcome of every single patient. And so see, believe, create, see that there was a problem, see how to address it, believe we could do it so you have the confidence, and systematically create an organized, simple, well-communicated system to stop it. And that worked. MDR-TB went down by 90% in the next few years, multi-drug resistant tuberculosis.
It's an amazing accomplishment. And I think one of the things that I don't think it gets lost, but shouldn't get lost, is that it's not just a technocratic thing of implementing strategies and tactics to solve these public health issues. Because I was struck by this story of a patient named Jorge and the outreach worker named Christian. Neither of them spoke the same language, but who had bonded over trust. And I think this idea of trust in public health is so important. So can you tell me a little bit more about that story and what it taught you about trust and, more than just sort of the Hallmark card piece of it?
Yeah. So it's a striking experience. I had, from when I started as an epidemic intelligence service officer, I had volunteered in the tuberculosis clinics on Tuesday mornings. One particular tuberculosis clinic because it was really near juniors. So I could stop by and get a delicious sandwich and a piece of cheesecake at the end of the session. And one day, Jorge, not his real name, came into my office. He was a man with hemophilia from Latin America. He was not legally in the US. He was working in an off-the-books factory. He had hemophilia. He had had transfusions. So this is 1990. I assumed he was going to be HIV positive. And he had TB. And he didn't really want to get treated. He didn't really want to deal with us, but he felt pretty miserable from his TB. But he was careful about his health. We got an HIV test. He was negative. So we were so pleased by that. But his tuberculosis bacteria was resistant to one of the antibiotics. And that meant that at that time, the recommended treatment would be thrice weekly, directly observed treatment. And he said, there's no way I can come to the clinic. I'm working from 8 a.m. to 8 p.m. I got to support my family. So I tried to convince him, and I speak passable Spanish. I've lived in Latin America. I get by in Spanish. I spoke a lot of medical Spanish because a lot of my patients were Spanish speaking. And he absolutely refused to participate in directly observed treatment. But he has drug-resistant bacteria. It's a thrice weekly regimen. You really can't give it except with directly observed treatment. And then Christian Wingby, which is actually his name, came in, and he was our outreach worker. And he had been a salesman in Nigeria. And he convinced Jorge to take thrice weekly therapy. Every Monday, Wednesday, Friday, Christian would go to a street corner about a block and a half from the factory. Jorge would go out. He was in crutches. He would come out in crutches, joints destroyed by the hemophilia, sit in the car, take his medication. Christian would bring him a snack and something to drink, juice. And after 9 months, we checked and documented that he had been cured. And what astonished me so much was that Christian and Jorge did not share a language. Jorge spoke only Spanish. Christian spoke Nigerian, several languages from Nigeria, and English, but not Spanish. But it was just he was a salesman. He cared. He expressed it. And I think this is one of the things that is so important, and one of the lessons of COVID, that we don't listen well enough, often enough. And often the first step in getting a message across is understanding where someone's coming from and how they understand the situation.
Yeah. So building on this theme of trust, I think one of the stories that I found absolutely fascinating was, this time around 2014 when you were at the CDC around Ebola, and how you had to break the news showing these projected million cases of Ebola potentially infecting so many different people. So I'm curious, leading up to the moment where you had to describe this, the table drop moment, can you walk me through sort of that hairy data preparation process? What does that look like when you're the head of the CDC? And how'd you know the data was, when did you know, and how'd you know that the data was good enough for you to confidently march in there and give everyone marching orders?
Yeah. So Ebola was the biggest crisis of my time at CDC. It was the first Ebola epidemic ever. It was the first time there had been Ebola in these West African countries of Liberia, Sierra Leone, and Guinea. And it was the first time there's been Ebola in an urban area. Ebola was really spreading explosively in the urban areas. And in the past, we and other organizations, MSF and WHO, had been able to work with countries, with communities to stop Ebola epidemics or Ebola clusters. This was different. This was kind of, these countries were in free fall. Their health systems were shut. More people died from malaria than Ebola because people weren't coming in for care. Women weren't coming in for cesarean sections, and so babies and women were dying. It was a real mess. And we couldn't quite express to people just how bad it was. And so there's a disease modeler named Martin Meltzer. He had done infectious disease modeling for influenza and other conditions. And he did a deep dive into the Ebola data to see what was happening, what would happen, and more importantly, in that C, part of the See, Believe, Create, to see not only what was happening, but to see the path to progress. What would it take to control it? And what he showed was things were increasing exponentially. Once we correctly looked at all of the case data, it was not, an exponential increase is very hard to convey to people because it's just, we don't think in terms of exponential increases. But it showed that, yes, there would be 1 million cases within less than a year unless we took urgent action. I didn't know that I believed him. And he and I went over and over and over all of the data, all of his assumptions, all of his models, till after midnight, day after day after day, until I was just sure, yes, this is correct. His model also predicted something really important, which was if you could get 70%, at least 70% of the people sick with Ebola cared for safely, and at least 70% of the people who died from Ebola to be buried safely, the cases would decrease just as rapidly as they had increased. I didn't expect that,
Hmm.
didn't think that made sense, but that's what the model showed. The risk of this explosive spread did galvanize US and global action. And we were able to get to the more than 70%, more than 70%. And the result was that cases decreased in exactly the time frame and the amount that Martin had projected. So it's a real
Hmm.
example of seeing the invisible, getting belief that you can do something about it. It's not hopeless. And then organizing with incident management systems, simple approaches to safe burial and safe care, speed, which was crucially important, rapid control to prevent it from spreading, effective communication with communities that were affected, because changing burial practices is very difficult. And with that, success in disease control.
Hmm. So part of being a public health leader is convincing folks, right, that what you're saying is something that needs to be done. And so, you talked about going to the situation room. So first, what is the situation room like? It looks very small.
It is
On
small.
TV.
It is small. There's you fit about 12 people around the room, and then there's a couple of rows on the outside, one row or circumferentially around it for people on the outside who aren't at the table. And there are a series of levels of meetings from
Really?
kind of lower level to the highest level with the president. And there was in the administration a very careful, systematic approach to vetting information and bringing it up the series of meetings, many of which would be either in the situation room or elsewhere, up to generally the main policy advisors to the president, the chief of staff to the president, and then, when necessary, to the president.
Mm. It seems also like, I don't know if you watched that old film Ghostbusters, where they're doing experiments in small rooms and increasing temperatures to, create more anxiety. But it kind of reminds me of that, like highly detailed, highly anxiety inducing information, small room, small group of very ambitious, energetic people. It seems like it could be, what's the word? Energetic inside that room, if that's a good way to describe it.
I mean, different administrations have different perspectives and different ways of
Mm,
working. Um,
mm,
so Ghostbusters, I've never thought of in that context before, but it's certainly a high pressure environment
yeah.
because the decisions are really life and death decisions. But frankly, life and death decisions are not limited to the situation room at the White House or even to state or city governments. Those kind of life and death decisions happen every day in doctors' offices, in budget decisions, and in what
Mm.
we do day in and day out.
So speaking of life and death, I think you talk a lot about COVID and how just basic organization was part of the big problem. So can you talk us through like what we didn't do in COVID and hope what we need to do the next time?
So for See, Believe, Create, the first part of the create part of this approach is to organize. In an emergency, this is what's called an incident management system, or IMS. And IMS comes from firefighting, actually,
Mm.
wildfires. And what the firefighters found was that if you break a big problem into less big problems, then you can manage them better. And if it expands even more, you then have a modular way of addressing those other problems as well. Incident management is what got us out of the Ebola crisis in West Africa, because we were able to support the governments to establish incident management systems, and they broke down the problems into logistics, clinical care, community education, research, fundraising, a series of different pillars, each of which could be managed to help the entire situation get better. But that's really just a special case of the importance of prioritizing. But if you look at 2020, the first year of the COVID pandemic in the US, there was no organization within the White House. You had many different factions doing things. And because of that, you really didn't have an organized response. And that was a big part of the problem. Another big part of the problem early on was the lack of effective communication. That the CDC literally wrote the book on how to communicate in an emergency. Be first, be right, be credible, be empathetic, give people practical, proven things to do. And the first Trump administration, did none of that in 2020. I think the Biden administration also got communication wrong because they insisted that CDC speak from the White House. And,
Mm.
a lot of people didn't like President Biden, didn't vote for him. We're in an increasingly polarized environment. And telling people from the White House get vaccinated is not going to get people who don't like President Biden vaccinated. So I
Yeah.
think in both cases, communication wasn't done as well as it should have been. And in terms of the next pandemic and what to do next, a lot of this has to do with supporting public health in the US and globally. This is one thing that my organization, Resolve to Save Lives, works on, helping and partnering with other countries so they can find threats faster and stop them sooner, because that's how we'll be safer. Safer here if they're stronger there. It's more efficient, more effective, and better to stop diseases when and where they emerge rather than waiting for them to come to our shores.
Right. Speaking of the next pandemic, as you reflect on the CDC today, and you talk about in the book all the time about how public health is woefully underfunded, but what does the CDC need? Obviously everyone would want lots more resources, but do you, like, tactically, if you had to spend, money, where would you put it, the CDC, to really make it infinitely more effective, let's say, for the next pandemic?
Well, first, let's say that CDC really is under assault these days.
Mm.
Its budget is being devastated. Half of its national centers are being closed. More than 2,000 of its staff have been laid off or otherwise removed from their jobs. These are people who kept us safe, and they can no longer do that. The CDC, for the first time ever, has had its director fired by a politician. It is now, for the first time ever, being run by political appointees. When I was CDC director, I was the only political appointee in the agency. They're now something like a dozen or more, and they're running the agency. This is really scary. This is a hijacking of CDC. Now, I don't think it was perfect before. And there are lots of things that I tried to improve while I was there. I think we made some progress, but not as much as I would have liked. The areas where I think CDC needs to be better, a better CDC, one, to be more tightly connected with state and local governments. Because I'm not saying that it should be dictating what state and local governments are doing. Quite the opposite. I think it should be understanding what local realities are. I was fortunate that I became CDC director after I had been health commissioner for New York City. So I had a much better sense than many people of, like, oh, this isn't going to fly in a local level, or they really need this and we haven't provided it. And I think you do that by putting thousands of people into state and local health departments early in their career and having them then either move up the ranks in the local health departments or rotate to CDC, where they can say, hey, this is how it works in the field. So more practical is one thing, and faster is another. I think as CDC got bigger, it got slower. And when I joined CDC in 1990, we were told if a state, city, or country requests assistance, either you will be on the airplane by sundown or someone else will be. And that kind of urgent response is still very much needed.
As you think about the assault on CDC, do you find an expertise just generally being under assault? Are you worried about the pipeline of future people coming into CDC and public health work, or have you seen tangible evidence that potential decrease in talent has already started?
I think there's a huge amount of worry in the schools and training programs, understandably, because many thousands of public health jobs are disappearing. At the same time, there's a lot of excitement. It's a great field. This is a place where you can believe in what you do. You can, if you're successful, prevent deaths, potentially millions of deaths. You can learn constantly because we're always trying to learn more about how to be more effective. And you can work with folks who are really dedicated to their jobs. So it's a great career, but it's currently under great risk. And because of that, our health is under great risk.
Right. In addition, we talked about trust in getting public leaders to trust you. And then there's also getting the public to trust you, which I want to get into for a second. So, one thing I read that I found fascinating was that, we've lost more Americans with COVID than all the wars put together, right? That the US has fought. And so I'm wondering, you also talk about the fact that there's this Cassandra curse in public health where you can predict what's going to happen and yet no one takes heed. And so I'm curious, like, as you think about that, and as your role as CEO of Resolve to Save Lives, what is the coalition that can be mobilized to help restore trust, right? So much of it is coalition building and strategy. What do you think can be done, to solve this trust deficit?
So trust is built over time and can be destroyed in an instant. So I don't think this is going to get better fast. There's certain things public health can do. It can communicate better, and that includes listening better. It can have small wins, things that people
Mm,
notice and care about, and that it delivers. And in terms of mandates, it can avoid mandates unless absolutely necessary. You raise a really important issue of coalitions, and coalitions are really important. We are stronger together. And we've seen coalitions of different groups. If you just look at what some of the industries that block public health work do, Coke and Pepsi hate each other, right? But they
mm,
get together to block things like soda taxes that would be really
mm.
effective at improving
Right.
health. So we in public health need to make coalitions, whether it's with healthcare or education or insurers or any other area.
Right. I want to stick on trust first, on the concept of trust, but you talk about mandates, right? And so obviously this was a hugely controversial piece of the COVID puzzle. And in your book, you talk about the different lighting systems, right? Like red being the time where a mandate might be most useful, and that they should, if I read it right, be mostly enforced through at the state or local level. Can you describe how your thinking on mandates has evolved? Because I think one of the things I took away from your book is that you need like laws and regulation are like hugely important levers, right? Like banning smoking in public spaces as an example, rather than relying on purely on behavioral change and convincing people. But it seems like for something like COVID that's so potentially deadly and you're dealing in an uncertain environment, instituting a mandate quickly might be really important. So how do you balance those two things, you know?
So I think we really need to distinguish regulation of industries that are harming people from
Mm-hmm.
regulation of individual behavior,
Mm,
for which the bar has to be a whole lot higher. For example, when we went smoke free in New York City, we didn't fine smokers. We told the restaurants and bars, you have to make sure your place is smoke free or you will get fined. So
mm,
that's much more acceptable than fining individuals. With COVID, we learned more. Initially, if you remember, when the first trials came out, it looked like these vaccines were so good that they would stop spread of the infection. They were what's called sterilizing vaccines. So they prevent people from getting it in a way they could spread it. It then became clear that protection, that very strong protection, it fades after about a couple of months. And so you didn't have anymore this ethical case to be made that, hey, you have to get vaccinated to protect other people who may not be able to protect themselves. And the reality is that once we learned that, it became clear that preventing or mandating someone to get vaccinated is more like mandating someone to wear a motorcycle helmet because it's
mm.
mostly to protect themselves. And that's something that's controversial and best done at the state and local level where you're going to have to enforce it.
Yeah. Where believe and trust, I think, intersect is sort of telling the public where the wins are. Talked about smallpox was this huge problem. It's eradicated. It's invisible. No one remembers it anymore as a huge public health triumph. And so, how do we operationally tell the stories of the successes in public health so that they're not forgotten?
One thing that my organization, Resolve to Save Lives, does is we
Mm,
have a periodic publication, Epidemics That Didn't Happen. And we
mm,
shine a spotlight on great work being done by healthcare and public health workers all over the world to prevent epidemics, because that's a way of seeing the invisible,
right.
what didn't happen. I think also we need to show progress. We need to say, let's identify problems, whether they're environmental contaminants or infections or cancers or other diseases, and let's document how big the problem is, the C. Let's do a systematic phased way of scaling up programs that work, believe, and then let's create a healthier future and show people that we've made that difference.
Tell me what you think of this. I really think public health is akin to civics in school. should public health be part of a civics curriculum? Because I think it is part of being a good citizen, is understanding, how we take care of each other, how we take care of society, if that is the basic framework for citizenship. And seems to me public health is a part of that. How does that grab you as a call to action?
I think public health is the organized action of society to protect individuals and society, and in so doing, not only help people live longer, healthier lives, but give us a more productive environment, a more robust economy.
One thing when it comes to trust is like sort of this idea of government overreach, right? And so I think whether it's banning trans fats or making workplaces smoke free, there's this maybe insult of nanny state. How do you deal with that criticism, when you're a public health official?
I think you have to go into the details. What are the specific things being recommended and what is being done? And for many things, it's really about empowering people with information, giving people information so they can take control of their lives. For some of the things, it's protecting people against harms of others. You don't want your kid being run over by a drunk driver. You don't want your water being poisoned by the factory that's upriver. This is no more nanny state than making assault and murder illegal. And then
Right,
there are
right.
some things in public health that can only be done when we really collaborate together. Uh, Getting a clean water supply, you really can't do it as an individual. You have to do it as part of a community. And this isn't nanny state. This is responsible government.
I totally agree with you. I wonder, before we move directly onto your book, what do you think the role of the modern physician is when it comes to public health? I think we don't get taught how to communicate public health issues in medical school, let's say on a regular basis to our patients. And so as I reflect on COVID, it seems like it was pretty easy to villainize one person if that was your goal, like Tony Fauci as an example. He could be the pinata, but it's hard to get mad at your primary care doctor. And so I wonder, do you think that there has to be more of a role with everyday physicians and being able to communicate effectively with our patients?
You used a crucial term, which is primary care. By one recent study, 100 million Americans don't have a primary care provider. That's just terrible. We spend
Mm,
$4.5 trillion, and primary care is crucial. Even with all the specialty care in the world, you need someone who coordinates it. You need someone to speak with the patient, to understand them, to understand their priorities, and then based on that understanding, to guide them with the options of how they can live a longer, healthier life. I think for individual physicians, some of the things that are really important are having a connection with your local health department so that you do know what is going to be most effective, what are the pathogens that are circulating in your environment at any one time, what are the recommendations that may be locally different for treatment of infections, and you can contribute to the knowledge of the health status of your community, and you can benefit from that knowledge to take better care of your patients.
yeah, absolutely agree. All right, so moving on to your book, what inspired you to get to write this book? What was the galvanizing? It sounds like you were writing this for 10 years, but you know, love to hear the origin story.
Yeah, during the Ebola epidemic of 2014 to 2016, it became painfully obvious that a lot of people didn't understand what public health is and didn't support it. And some of the people doing it didn't have all the tools they needed to succeed. And so, for that problem, I thought it would be really important to tell the story of what really is public health and how can it succeed. Why should people care if their health department is effective? And what can it do, not just in the past, but in the future? Yes, it's had great accomplishments before, but what can we do now to make an even healthier future? To answer that critical question of how can you save the most lives? So it took a long time to do the research and to frame it and to recognize actually that there is an approach that's been proven to save millions of lives, a formula: see, believe, create. And that was new. And getting that clear to people and understandable, cutting out the parts that people would skip, making a book that I hope people will enjoy reading and will also give them useful information for their own lives and for their communities, and also be helpful for doctors and people working in public health. That's the goal.
Yeah, no, I loved reading it. And one of the things that I found striking is your advocacy of treating hypertension. And what's striking to me is in the halls of medicine, I'm at a medical school, big university, the discussion of hypertension is so minimal relative to its public health impact in our daily lives as physicians that I really found that astonishing. So can you talk about why hypertension really rose to the top of your framework for this invisible pandemic?
High blood pressure is called the silent killer for a reason.
Right.
Most people don't have any symptoms until they have a heart attack or stroke. And even the concept, oh, I can tell if my pressure's up because I have a headache, usually wrong. So it is the kind of absolute paradigm of a silent killer of an invisible but high priority condition. And it is so neglected. I will tell you, when I was health commissioner, we started an initiative to put electronic health records into the poorest, sickest neighborhoods in New York City, the South Bronx, Harlem, and Bedford-Stuyvesant. And the Dr. Farzad Mostashari, who's now our board chair at Resolve to Save Lives, was the head of digital health in New York City. And we proposed a program to put in these electronic health records, and we got it funded. And then we were meeting in my office, and we asked the question, it's like, well, how can we save the most lives with healthcare? And it's a very straightforward question, but amazingly, 10 million plus articles in Medline, not one of them answered that question. So we had to do the analysis ourselves, and the answer is crystal clear. It's treat hypertension well. And if you look in the US or globally, it's a mess. I mean, in the US, our control rate is less than 50%. So for $4.5 trillion a year, we can't even get the single most important thing done half the time. And that's with a target of 140 over 90. People with diabetes should certainly have a target of 130 over 80. I have hypertension. My target for myself is 120 over 80 because that's the healthy level. Starting at 115 over 75, your risk of a heart attack, stroke, or death doubles with every 20-point increase. The medications are safe, they're effective, but we don't do that kind of simple program that Carol Stiebler showed for tuberculosis. How did each patient do? How did we really do with control? So hypertension is so important, not just because it's a huge burden, but because it's quite controllable. If you look, though, at global health, this is an astonishing statistic. There's a lot of money that goes into global health. That's a good thing. High blood pressure kills more people than any other cause. It kills more people than COVID killed in the worst year of COVID and at a younger age. It kills more people than all infectious diseases combined, HIV, TB, malaria, all of them. And it gets less than $1 out of every $1,000 that goes into global health.
That's crazy.
And that's part of the reasons we created Resolve to Save Lives, to try to change that. And we've now worked in more than 40 countries and supported programs that currently treat more than 40 million patients. We've identified what the real bottlenecks are and challenges, and we're working with countries and with donors to try to overcome those challenges. But this is why all of the proceeds from the sales of this book will go to programs like the hypertension treatment and epidemic prevention programs around the world, because this is an urgent problem that's not being well addressed, and we're implementing the formula to save millions of lives.
So you talk a lot in the book about, in these various public health challenges you've encountered about technical packages. So what is the technical package for treating hypertension?
So a technical package I learned from this same amazing scientist, Carol Stiebler. All too often, people try to do everything, but it turns out that if you can keep it simple, Identify 5, 6, 7 at most things that need to be done and done right. You can get great results. So for hypertension, we worked with the World Health Organization, the CDC, and others to come up with what's called the HEARTS technical package. And it's really 5 components. Choose a protocol, a simple linear protocol to treat patients. Second, make sure you have enough medications and validated blood pressure monitors. Third, make the caregiving part of a team, because team-based care with nurses, outreach workers is much better than individual patient care. Fourth, make the services patient-friendly. And that means make the medications free or as close to free as possible. It's an asymptomatic condition. If you have large copayments, people aren't going to continue for a lifetime. And fifth, have a powerful information system so that you can actually see how patients are doing and improve how they're doing.
Got it. As you've implemented this across so many countries, it seems like Africa tends to be, or so many of the countries in Africa tend to be a really successful sort of staging ground for all these efforts. What has gone really well? What has not gone as well as you've expected or hoped for?
One thing that's gone very well are choosing protocols, because it turns out there really are only 3 medications that you need to treat at least 80% of people effectively. And they're all generic. They're all low cost. The costs have come down astonishingly. It now costs less than $5 a year to treat someone, including with statins if they need them, because statins are much underutilized. We've also found in many countries, not all, a real willingness to do team-based care and task sharing. So that's been very positive. We've also found a willingness in some countries, not all, to really make services patient-friendly, free of cost, decentralized, so they're really close to the patient's village and they don't have to travel long distances. The 2 areas that haven't gone well are medication access in some countries and information systems in most countries. Medication access, some countries don't have a problem. So countries like Philippines, Indonesia, India, they've got strong production capacity, they've got strong funding capacity, and they have a commitment to provide medications. Not really an issue. There may be bumps in the road as you scale up the program, but they can get it managed. For the lower income countries, Bangladesh and most of the countries in Africa, even $5 a year is too much for their current budget. So that's a challenge that has not been addressed. And we hope philanthropy and drug companies that are willing to donate can build local capacity to make these drugs affordably and provide them free of charge to patients. But that hasn't happened yet. The other area is information systems. And here, it's been painful to watch. We built a system. It's called simple.org. It works super well, but every country wants its own system and it wants it to do everything. And what we found in most countries is that the digital systems that are being used are very ineffective. They're very cumbersome. They're not helpful for healthcare workers. They're not accurate. They've cost a lot of money. And you basically have this dynamic where country leaders think an information system is going to be quick, cheap, and easy. And the vendors tell them, yes, it will be. Just give me $1 million and then another million and another million and another million. And so in literally dozens of countries, we've seen information systems that have been expensive and are not meeting the needs of healthcare workers or patients. And that's a problem that can get addressed, but it's going to take some hard work and prioritization.
Speaking of information systems, I'm glad you brought that up, and sort of incident management systems. Did these get recreated from scratch every time, or are there actual health infrastructure, digital health infrastructure, or reporting infrastructure that can be easily kind of deployed and scaled up? I'm just curious, how that might work in your life.
Yeah, we don't really have the modular approach. There are some systems out there. One of them is called DHIS2. It's used in more than 70 countries, but it's mostly an aggregate reporting system. We've collaborated with them to rebuild our simple approach in their software because many countries use that. Often what you have is kind of like the power plug problem. that each country has its own and they don't want to change. So what we've found within the US and globally is countries either have something they're using and they want to stick with it, or they want to build something that's theirs. And it's good to build something that's yours, but it'd be really good to do it based on the best practices from around the world and a realistic assessment of what's the connectivity, what's the electrical supply, what's the hardware, what's the computer literacy, how much time do health workers actually have. We're very focused on a user-centric approach to digital design. Everyone talks about user-centric, but not many people do it. See, how long did it actually take the nurse to do that work? With our simple app, the team looked over and over and over, and they said, if it takes more than 20 seconds to do data entry, it's not going to be used. And they got it down to 13 seconds for more than 1 million patients a month. But oftentimes you have really smart, very dedicated people working at the central level saying, well, I want all of this information. Well, if you're getting all of that information, it's going to take the health worker maybe 3 or 4 minutes, and maybe they only have 2 or 3 minutes for the patient. So you're not going to get it done. So you have to be realistic about what's out there.
I love that. The other question I have for you is that given the burden of disease of hypertension, right? You talked about how one of the most effective pillars of treatment is this team-based approach. So how do you see team-based care scaling, right? If we're going to kind of manage the actual incidence of disease?
Yeah, I think actually team-based care is more scalable than other forms of healthcare, because what you're doing is essentially getting the average salary cost down by involving community health workers, nurses, advanced practice nurses, community health officers. As a team, you're able to provide better care for less money. And that's really important.
I agree with you. I wonder, how's AI, going to be able to help us if everyone has a free or nearly free AI coach?
I got to say, I think for healthcare providers also, AI will be transformational. I was on a flight recently and a fellow passenger was ill, and I didn't feel comfortable taking care of them without consulting AI. And in fact, AI raised a possibility that I had never heard of and that might have been relevant in this case. So
interesting, yeah.
I think of AI as another member of that healthcare team. We talked about team-based care. Well, AI is a team member, and it's a team member that has really bad judgment, but an amazing store of knowledge. And some of the tools don't make any of that knowledge up. So I think it's become an indispensable part of care. I would not feel comfortable caring for patients without access to AI. I think it's that essential these days. But it's not yet widely available, particularly in lower and middle income countries. It needs to be. We haven't really figured out how to integrate it into primary care. That's really exciting. We have some projects at Resolve to Save Lives where we're working on that, and we're looking for funding to do that and other things. That's the kind of things that we'll be able to fund with any of the proceeds from the sales of the Formula for Better Health.
That's amazing. So as we hit the home stretch here, I'm curious, so much of your book is not just about the next public health leader, although it applies to that, but also individuals in their everyday lives, right? So can you walk us through some of the most impactful everyday actions we should be taking to live a healthier, more productive life?
When you take an epidemiologic standpoint, you look at what's really proven to make a big difference. You get the big six. And the big six are: control your blood pressure, ideally to under 120/80. Control your lipids, ideally to get your LDL and your ApoB under 70. Get physical activity at least 4 days a week, at least 30 minutes each time of at least a brisk walk, ideally outdoors. Sleep enough, 7 to 9 hours of sleep. Avoid toxins, particularly tobacco, alcohol, but also PM 2.5 and some of the newer toxins. And then the toughest one is to eat healthy. And with nutrition, there are a lot of debates about what's healthy, but there's some things that are very clear. We have a potassium deficiency, most of us. If you consume more potassium than sodium, you'll have major benefits. If you reduce sugars, you'll have major benefits, especially sugary drinks. If you eat more fiber, there will be some benefits. If you avoid processed meat, there'll be some benefits. So those 6 are really quite accessible, and it gets lost in a clutter of hype, of grifting, of sales of stuff that isn't proven, of sloppy thinking. There are another set of things that are helpful that I go through in the book to reduce the risk of dementia, because dementia is such a risk. But we can prevent about half of all dementia with currently available things. And that starts with things like controlling blood pressure, but it also includes some things that are more surprising, like speaking a second language regularly or playing a musical instrument.
Mm-hmm. The other one, I don't know if you're familiar with him, but Jonathan Rosen runs the McCann Center for Brain Health at Harvard. And so they have the brain health scoring. Among those things in the brain health score are your A1C, I think your blood pressure, and then the strength, social connections, and so while it's hard to like action that sometimes for some people, I do think that that's incredibly important, is to like maintain healthy social connections in your life as a health strategy.
It's a really good point, Rohan, and the data on it is pretty strong. There's a pretty I reviewed in the course of researching this book. I reviewed in detail every single one of these things, and going back to all the major studies, assessing them, seeing strengths and weaknesses, and actually the data for social connections promoting longevity and reducing dementia is real and probably accurate. What is challenging is exactly what you say, is how actionable is it? If someone is not socially connected, there are actually no studies that document interventions to increase that social connection. But if you're an individual, there are things that you can do. You can join groups, whether it's at a local something or with friends. You can connect more with family. So important, but harder to do. We talk about burden and amenability. The burden is really high. Amenability is more challenging, but possible. The other thing that is quite strong is the evidence that correcting vision and hearing reduces the risk of dementia and prolongs life.
Yep.
There's this emerging data that the shingles vaccine may reduce the risk of dementia. So interesting stuff.
You talked about exposure to toxins as part of the 6. And, as I think about the MAHA movement, right, and, while I disagree with much of what is said, I wonder whether, this is the broader point about what's in our food supply, what are we exposed to, something where there's common cause to be had, microplastics. I'm sure you saw that study of microplastics in the atheromas of people's carotid arteries and in the brain, the endocrine disruptors, the PFAs, et cetera. So I'm curious, is that the next frontier of public health? Like, you talk about a little bit in the book about how there's a difference between proving it's harmful versus it's safe. How would you tackle this problem?
I think with respect to the current administration, it's really important to separate what they're saying from what they're doing. Because a lot of what they're saying makes a lot of sense, and it taps into a real suspicion and concern and valid worries about what's in our food, what's in our water, what's in our air. Where I think there are problems are, first, when you're rolling back protections against known problems, ending, for example, the tobacco control activities of CDC, stopping the regulation of tobacco companies. This isn't taking on chronic disease. This is opening the door to chronic disease. And yeah, it's great to say we're worried about PFAS, but what has it done? It's actually delayed cleanup of our water from PFAS. PM 2.5, soot, causes an estimated 100,000 deaths a year in the US. They've rolled back regulations that protect people against it. It's, in the name of deregulation, it's open season on our lungs, basically, from polluting industries. But for the kind of newer, I consider them the big 3, microplastics, endocrine disruptors, and nanoparticles. There are real risks here. We need to learn more about them, and we need to restrict them wherever possible and appropriate. there is a challenge. They're pervasive in our environment, and figuring out which are the most deadly, which can be dispensed with, which may be okay, that's really important. And that's going to take time, resources, and rigorous science.
All right, last big question, which is, you're very outspoken in the book about the pernicious effects of misaligned incentives in healthcare. The importance of primary care, how it's not funded appropriately. What do you think are the strategies to get us to a better place? Are you excited about value-based care, where that can go? Is our current system of payers, between insurance and government, going to get us there? I'm curious, like, are there health systems where you are very envious of how they achieve outcomes and the outcomes they achieve?
Well, there are health systems around the world that have strong primary care teams. Thailand, Costa Rica. I've seen both of those country programs, and it's really impressive, where you have a group of health professionals working together who take responsibility for a community and understand the needs of that community and deliver really useful healthcare for that community. There are countries around the world where primary healthcare is much better. In many countries in Latin America, Europe, Scandinavia, you have really strong primary healthcare systems, and that improves outcomes and reduces costs. Where I think there's a real challenge in the US is we have a system that's very expensive and not delivering high value. It provides great, highly specialized care. If you have a complicated medical problem and you get into the right institutions, you're going to get the best care in the world. There's no question about that. I'm not maligning the expertise of our health system. But if you want to stay out of that problem with a good preventive care, we need to change the economic incentives. And there are programs like the physician-operated accountable care organizations where basically, look at Kaiser Permanente. Kaiser Permanente takes care of millions of patients, and they do that as well as any health system in any country, anywhere in the world. Why? Not because they're smarter doctors, but because their economic incentives are aligned. They are both the payer and the provider. So if they reduce illness and therefore reduce utilization, they do better financially. If they fail to reduce illness and therefore there are avoidable hospitalizations, they do worse financially. So their incentives, the provider's incentives, and the patient's incentives are all aligned. We need to put that into more of our healthcare system so that if a primary care doctor does a great job and their patient doesn't get hospitalized, that primary care doctor should make more money. And there are some examples of programs like that in the accountable care organizations that are physician-operated. I think that's one way forward to show phased progress. But it's going to take a commitment to primary care that's not simple, especially with an aging population that has a large number of conditions that need long-term care. We'll only get great care if we make a big change in how we finance healthcare in this country.
Love that. All right. So now we're on to this last section, which we call quick hits. So most impactful mentor in your career or life?
My father. My father said, you got to help the people, and just focused on rigorous, proven interventions to make the biggest difference. He was a deeply caring physician, and he showed what it is to be evidence-based, rigorous, and able to save a lot of lives.
Book recommendation?
Factfulness by Hans Rosling. Wonderful book. Teaches us a lot about how to see the world more accurately.
And that dream dinner guest, dead or alive?
Oh, dream dinner guest. Well, it'd be fun to talk with Socrates.
You seem like a cerebral guy, so I can see why that would, get you excited. And then for the next episode of Good Medicine, who should we have, and what would you ask them?
Wow, that's a tough one. I think it would be really important to talk to someone who's run a health system effectively. For example, you could talk with one of the leaders from Thailand who helped their system get established, like Dr. Suwit, who has been a passionate advocate for healthcare and primary care for many decades.
Lovely. Well, that is our episode of Good Medicine. Thank you so much, Dr. Frieden. This was an amazing conversation, and I'm so inspired by the work that you and your organization have done. And I hope everyone picks up a copy of your book. And last question, actually, is how can people support the great work that your organization is doing?
You can get onto our website, Resolve to Save Lives, or rtsl.org. You can see what we're doing. You can donate. And all of the proceeds from both the sales of the book, The Formula for Better Health, and also the Substack that is called The Formula, go toward supporting programs like the ones we've talked about to stop epidemics sooner and treat hypertension better.
Amazing. Well, thank you, Dr. Frieden. This was great.
Thank you so much. All the best.
Thanks for listening to Good Medicine, and a special thank you to Dr. Tom Frieden for sharing his perspective. If you're a physician, we'd love for you to join the Roon community at roon.com. That's www.roon.com. You can also help us grow by sharing this podcast with a colleague or friend. Until next time, thanks for being part of the conversation.